So we're going to talk about a little bit in more detail about exposure techniques. That's one of the things that I think can be the most difficult. I remember being a student and thinking, how am I ever going to learn techniques? And that was before they were, built into the equipment. So you either had to have a little pocket notebook or something to remember, what to use. I mean, they did have technique charts, but it wasn't as easily accessible as it is now, where we have APR and it's built in. So over the years, I've had students say that's one of the most difficult things to actually learn. How do you know what KVP and mass to use for different things? And so that's why I'm the pocket notebook. I had one, just a little spiral bound notebook that I kept in my pocket for the first year after I was out, working on my own. And I would write down, everything, and especially things that you didn't see a whole lot, like, scapulas or sternums, things like that, so that I would have a reference. So we are all going to talk about a little bit more about APR, which we've already covered when we covered AEC, but talk about the two different types of technique charts that may be available. Things that you would have to modify techniques on a technique chart for. So things like the patient being pediatric, geriatric, bariatric, varying projections and positions. So, how do you change your technique if you're going from an AP to a lateral lumbar or an AP to an oblique lumbar, which you'll be doing in lab for Yolanda next week, I believe. How you adjust if you have soft tissue, if they're specifically looking for soft tissue, if the patient has a cast or a splint, if we're using contrast media, and how pathology can affect, our determination of our technical factors. So why do we need technique charts? Because it gives us a standard selection of factors for a typical patient so that quality is consistent. So when we say typical, that's very subjective. So you're gonna sort of learn what you feel like is typical, meaning size-wise, like you'll know what normal or medium or small or large is to you, and then you'll use that to make your adjustments to your technique. We don't need to just be guessing, right? For one reason, we'll see in a couple slides, is because DHEC requires technique charts. That's one big reason. But APR, is anatomically programmed radiography. It's basically just a programmed in technique chart. So, excuse me, if you click on lumbar, then it will usually pull up AP, oblique, lateral, spot, and you would choose those, and it would be pre-programmed in there. So everywhere you work now probably has this. Has anybody worked in a site where the room did not have APR? Like where you just, all your setting is KV and MA and time, or KV and mass, where it didn't have anything that you choose? Probably not. I can't think of anywhere that has that anymore. So South Carolina Department of Health and Environmental Control states that for general radiographic systems not equipped with an operational APR, protocols shall be documented and readily available to the operator. So what that says is, if your machine doesn't have APR, then there better be a technique chart readily accessible to that piece of equipment for you to use. We shouldn't just be, winging it. However, technique charts or APR do not replace the need for critical thinking skills. You still have to be able to use individual judgment for each patient. So there's going to be things that come up that will make you have to vary, the standard that you're given on a technique chart for different reasons, and we'll look at those. Conditions for technique charts to be effective. First, the equipment must be calibrated to ensure that the KVP, MA, and exposure time settings are accurate. So you can see why that's important. And we're going to test these things coming up in lab along about week 9 or so. We're going to start doing that in the lab. Because if you're setting 80 kVp, but that's not really the kVp that you're getting, do you see how that's a problem? That's a problem for not only the technique chart being accurate, but for the patient. So we're going to test that. Second, image processing must be consistent. So again, this was more important when we were talking about film. Processing of the film had a lot to do with the image quality. So, God bless you. So processing now is part of the direct digital system. So it is still important, but it's not like when we were talking about actually putting a film going into a darkroom and putting a film in a processor, where if the temperature of the processor varied 1 degree, it made a huge difference in the way that the film came out. If it was 1 degree higher than it should have been, your films would come out darker. If it was 1 degree cooler, they would come out lighter. So it was a really big deal back in film days. Once the chart is developed and tested, it should not be altered by individual techs who may not be using the correct distance, grid, etc. So if you have a technique chart and you go in there and you don't make sure your distance is what the distance is indicated on the technique chart. So let's say the technique chart says 40 inches and you go in there and you have 55 inches and you use the technique for 40, it's not going to be right. It's going to be underexposed, right? Because you're using what you thought you should use at 40, but you're really at 55. So you don't want to go, that technique didn't work. Scratch it out, put yours up there, because then the next person who truly does use 40 inches, now it's going to be what? Too dark. Well, dark, we said it. It's going to be overexposed. So you want to make sure that if there's you see a pattern developing where you are at 40 inches and you're doing everything like the technique chart says, you're using the correct grid or not using a grid or the distance or whatever, and it's consistently coming up wrong, then you need to report it to either your supervisor or whoever's taking care of that. So then they can do some testing and say, yeah, maybe it does need to be adjusted. That technique does need to be adjusted, but don't just do that on your own. Periodic checks and updates of the chart with input from staff radiographers. That's what I'm talking about there. So if you see that it's not working consistently, then y'all can, make some changes. Standard factors that are generally included in a technique chart is the anatomic part, the position or projection, KVP, mass, SID, whether it's grid or no grid. AEC can be a part of a technique chart. So, for example, maybe pelvis has 75 to 80 kVp, outer photocells, normal density, sorry. So AEC can be a part of that, like just telling what photocells to use and what density setting to use. And then a part measurement or a size grouping of some sort. It'll generally either have centimeter measurements, like this is considered small, medium, large, or just those categories, small, medium, large, maybe extra large, maybe extra small, just so you have a general idea of what technique to use depending on your patient's size. So there's 2 types of technique charts: variable KVP with a fixed mass and fixed KVP with a variable mass, which is more common. That is generally what you're going to see out there is a fixed KVP, meaning when we say fixed KVP, like a KVP that has a range, a certain range, and then the mass is varied depending on the thickness of the patient. Both of them have advantages and disadvantages. So we're going to look at each one and talk about that and how you calculate changes based on whether or not it's a variable KVP or a fixed KVP. So we'll look at the more uncommon one first. Variable KVP fixed mass works off a baseline KVP, which is the original KVP value predetermined for the anatomic area to be radiographed. That's determined experimentally, can use 50 plus twice the thickness of the part as a starting point. Where did we talk about that? That should sound very familiar to you. That can use 50 plus when did we do that? Do y'all remember?
When we talked about KVP.
Yes. So in lab, when we talked about KVP and we talked about minimum KVP that it would take to get through a particular part, we said we can use 50 as the base because it takes at least, and books don't really agree on that, but that's why I would never ask you a test question like that. But I would have to say 50 is the base or 40 is the base, whatever. But in our case, we say if 50 is the base, then remember we used for every 1 centimeter of increase, which is what this next line is saying, for every 1 centimeter increase in the part thickness, you increase it by 2 KVP. Remember that? So part measurement is critical when you're talking about a variable KVP fixed mass chart. You would use calipers for that. Remember the calipers that you guys use to measure each other? So for example, if a standard technique for a patient's knee measuring 10 centimeters is 63 KVP, 20 mass with a 12:1 table Bucky grid, if the patient measured 14 centimeters, what would be the required change in KVP? Does anybody want to give it a shot? Take a second to look at it. 71. Does everybody agree with 71? Nobody cares? It would be 71 because the change in part thickness is what? 4 centimeters. We're going from 10 centimeters to 14 centimeters. So that's 4. 4 times 2 is 8. 63 plus 8 is 71. So that's how you would adjust, and the mass would stay the same. That's with the variable KVP fixed mass type of chart. So the nice thing about it is that it's easy to construct, simple to use. At low KVP levels, small changes in KVP are more effective than changing the mass. So that's some of the advantages. Some disadvantages of that is that anatomic part penetration might not be guaranteed. It's less accurate for part size extremes. And we know that changing the KVP varies both the contrast and the amount of scatter produced. So those are reasons why typically we don't use that type of technique chart. We would use the fixed KVP variable mass. This is what you're going to see more often than not. And when I say that, I mean programmed into the APRs. Or let's say your APR is programmed for what we would call a typical size patient. Then if you have somebody that's much bigger than what you would consider typical, then you're going to leave the KVP alone generally and just adjust the mass, which is what that's talking about. So some advantages of the fixed KVP, the use of mass to change receptor exposure, which we like, right? Because mass only affects receptor exposure. That's why we like to use this kind. It doesn't affect spatial resolution, distortion, contrast. It only affects receptor exposure. So that's why we like to change mass to control receptor exposure. It uses optimum KVP for the body part. So we know that it's going to be adequately penetrated, and it will produce sufficient contrast and an acceptable level of scatter radiation. So in general, the guideline is for every 4 to 5 centimeter change in part thickness, the mass should be adjusted by a factor of 2. So you do have to know these rules. Just remember that in both situations that you're talking about the same amount of part thickness difference, 4 to 5 centimeters here. With the KVP, it was 4 centimeters. So if your part thickness changes by 4 to 5 centimeters, then you're going to adjust your mass value by a factor of 2. So of course, if your part thickness is 4 to 5 centimeters more, you're going to use twice the mass that you would have used at the normal thickness. Does that make sense? And then if it's 4 to 5 centimeters less, you would use half. Okay. So let's look at another example. If the patient's knee measures 10 centimeters on a fixed KVP chart, and you would use 63 kVp 10 mass on a 12-to-1 grid. If the patient measured 14 centimeters, what would be the required change in mass? Somebody besides Maya.
20.
20. Does everybody agree with that? Yeah, because a 4 centimeter increase in part thickness requires a doubling of the mass. So we would go from 10 to 20. So that's another way that you can learn to adjust techniques in clinic. You know, measure, get an idea of, I know it's hard, but get an idea of, well, what is 4 centimeters? What is that? So measure your hand or whatever, just like you would do for finding your, your landmarks in Yolanda's class, so that you can sort of know, because you may or may not have access to calipers in clinic. Has anybody seen any calipers out there in clinic anywhere? Some of your bigger, like hospital type settings probably have them. We used to use them a lot when we were doing a lot of tomography, because you had to measure, because you had to figure out, what level was a particular part that you were trying to, make a cut through. So to produce a technique chart, primary tools, phantoms, caliper, and calculator. So radiographic phantoms, real human bones are the best. So like the phantoms that we have, except for a few, have the acrylics have real bones in them. I tried to pull all the non-real bones out, except for the couple of abdomens that we have. Those are not real bones, but because they simulate the thickness of the body part. And you can test technical factors without exposing the patients, not just using patients as guinea pigs. So you have to have some phantoms, not like the blue guys. Those are worthless to us when we're talking about creating a technique chart, because you've heard us say 100 times in lab, you would never use this on a patient, right? When you're talking about using one mass on a spine or something, that would never work on a patient. You have to have some calipers to be able to measure the path of the central ray through the thickest part. And then you have to have just a basic function calculator. And you'll use it when a correction factor is needed from a working technique chart. And we'll talk a little bit about that in just a second. So how you would produce an accurate chart, you would use your phantoms, produce radiographs with a suggested mass and KVP from a working technique chart used in another facility. So for example, in the lab, we took, excuse me, the technique charts that we had for the old rooms, okay, when we were in the other building. We just brought that forward. And that's why we have been making corrections as we go in these new rooms. So we took a chart that did work in another place and we brought it over, and now we're just going through, and as we shoot them, we're making corrections. We need to check our exposure indicators. You have to understand the relationship between receptor exposure and your indicator, meaning you have to know if your exposure indicator has a direct relationship to exposure or an inverse relationship. So in our case, in the Siemens rooms, it has what kind of relationship to exposure? Direct, right? Because if the EXI is a little over the target, that means we were a little overexposed. If it's under, we were underexposed. So you have to know that, especially there's a lot of places out there that have S values. So Easley people, these are Easley folks. Any Easley people? So they have S number, right? So that's inverse. Some of the St. Francis rooms, I think, have S number, like East Side, maybe. So you have to know that. You have to know what kind of relationship it has. When your exposure indicator is on target and image quality is good, then record those technical factors in your chart. And that's what we're doing in the lab as we go through this first time that we ever use those rooms for the labs. So how do you use correction factor? Well, for example, let's say you expose an abdomen phantom at 85 kVp and 20 mass. And suppose your exposure indicator is an EI and your target's 400. Okay, so there is EI out there, and that would be the target. So if your EI comes up 600, then you know it's overexposed, because EI and exposure have a direct relationship. So if the target was 400 and our number came up 600, that means we were overexposed. Okay, so how do we figure out, well, how much would we adjust? You just put that in a ratio, okay, in a direct relationship, because that's the kind of relationship that EI has to exposure. So you would just put your 400 over your 600, because we know that we used too much, and take our mass that we did use that gave us 600, you put it in a ratio, and you would just cross multiply, solve for X, and your new mass value would be 13, which makes sense. 13 is less than 20. So that should reduce your EI down to about, I do this all the time in lab. Have y'all heard me say, wait a minute, let me figure out what we should use? That's all I'm doing, is just throwing it into a ratio. And I wish I had my pencil. So you would put like X over 20 equals, and you're keeping it in a direct relationship. So if I'm looking for X to give me 400, right? I'm keeping that in a direct relationship. If 20 gave me 600, that's all I'm doing. And if it was an S value, then you would do it inversely, because it's an inverse relationship. So in the same example, your exposure indicator is an S value of 200 and your target's 400. Then this would indicate you were overexposed, because S value and receptor exposure have an inverse relationship. So again, you just put it, like I just said, you would put the ratio in an inverse relationship and solve for X. So your value for your chart would be 10 in this case. So, and we actually, several years back, we had a student that went to work in a small place. I can't remember if it was a chiropractor's office or just a very small doctor's office, and they didn't have any kind of technique chart to go by. So they borrowed some of our acrylics and came up, took a technique chart from somewhere else and used those acrylics to create their technique chart. So that's been a few years ago. I really don't foresee that happening now, but possibly it could if you go to work, and like if a chiropractor actually has business enough to hire somebody to do their x-rays. A lot of times they do their own. But anyway, so it's not totally out of the question that you might have to do that at some point. Proportional anatomy. Now, this is another thing that's going to be very helpful to you, to help you know what techniques to use when you're out there. Proper radiographic technique for one body part can be derived from a known technique for another body part. So anatomical groupings that share the same overall technique. So you might have already looked at the slides, but so what would be an example of like a proportional anatomy example that you could give that you could use it on this, but you could also use it for this. Anybody look ahead? So for example,
like two things that you use.
Yeah, like my shoulder and my knee are basically the same size, thickness. So if I know what to use on a knee, but maybe I haven't done a shoulder, as a student or whatever, then I could really go with what I would use on the knee for the shoulder and probably be fine. So that's what this is talking about. Proportional anatomy groupings. So for example, if you use 80 kVp at 30 on an AP abdomen of average size. So for example, let's say if we're using that on my abdomen, then do you see how we could also use that for my pelvis, for my lumbar spine, for my T-spine probably still would be okay. My hip. If you can figure out what you use for one area, then, things that are very similar, you can use the same thing. So this would be an example of, I could probably use 80 at 30 on any of those things, and it would be fine. It at least get me in the ballpark. Does that make sense? Okay. So when we went to digital imaging, it was suggested that digital allows an increase of KVP values about 15% across the board so that mass values could be cut in half. And this could be done without noticeable change to the displayed image because the computer software, is what's controlling the contrast. This would lower patient dose. It's just something to think about. So when we went originally from film to CR, for example, we just wanted to keep using what we were used to using, right? We didn't want to, we knew what to use and we didn't want to change. But what this is saying is really it was okay to increase like across the board KVPs by about 15%. So we could cut those mass values in half, which saves patient dose. Because we don't get the result when we increase KVP 15% with digital that we got with film. Like we had a noticeable difference in contrast when we did that with film. So that's why we were so resistant to doing that. But now you can pretty much see across the board that that's what has happened. We're using much higher KVPs than we used to use when we were using film. So let's look at some individual situations where you will, have to make some adjustments to what's given on your APR. So if it's a pediatric patient, so generally for patients less than 6 years old, you need to decrease the KVP to compensate for the lack of bone density and also cut your mass in half. So for example, if your room is programmed for adults, for example, your APR is for adults, then if you have a pediatric patient, you don't want to use the technique that comes up for that adult. Generally, and it depends, like if it's a big 6-year-old, you might could get by with it. But if you're talking about a 2 or 3-year-old, then generally what you need to do is decrease your KVP some and cut your mass in half to compensate because they just don't have all their bones initially. With peds, you always want to try to use your shortest exposure times possible. Why?
They move along.
Because they move a lot, right? So you want to have your technique set with the shortest exposure time you can possibly have to hopefully keep from having motion on your image. You should only use the AEC if the part covers the photocell. So most of the time, if you're using AEC with children, you're using the center photocell, not usually using the two outers. Why? They're not that big. They're not big enough to cover the outers. So generally, if you are using AEC, you're going to use the center. Limit the use of grids when possible. So I know we've been talking about grids, but with children, we typically don't really need grids, right? Because their part thickness does not meet the requirement. And generally, we're not using really high KVPs on children. So you usually don't need grids for kids. And make sure you check your exposure indicators. You don't want to, do a foot and not check the first one and it be way overexposed and do the other two with it way overexposed. I know it's just a foot and I know we're not talking about huge mass values, but still, ALARA, right? It's a bottom line. So geriatric patients, the ability to follow instructions may be impacted. Take more time, use pads on the table when you can, give them blankets, be careful moving them. They're different. Their little skin is like paper. You can just tear it off, not even trying. They have no cushion a lot of times, so their little bones are poking through, and it hurts them when we drag them across to the table, right? So we have to treat them different. We need to treat everybody with kid gloves, but you know what I'm saying, especially little elderly people. And again, we want to use this shortest exposure times possible because they a lot of times revert back to childlike things, right? Like trying to hit and things like that. So we want to make it short exposure time so we hopefully prevent motion. Bariatric patients, consider the table weight limits. Usually requires an increase in both KVP and mass. So we're talking about morbidly obese patients here. You have to use your grids with those patients because of the amount of scatter that's going to be produced. They may need to be imaged in quadrants. So it is not unusual these days to have to do 4 for an abdomen so that you include everything. Hillcrest folks, who's our Hillcrest people? So they do a lot of bariatric surgery at Hillcrest. So I don't know if that increases the number of bariatric patients that you guys see at Hillcrest, but it happens really frequently that you have to do that, or possibly 3 images, 1 for the lower and then 2 for the upper. Again, check your exposure indicators, like do your first one and see if your exposure indicator is good before you do your other 3 quadrants. There's not real specific instructions about where it says techniques may need to be decreased. There's not like, hey, do this. It's just, you should be able to look at the patient and know whether or not, you need to decrease your techniques based on whether or not they're very frail or very thin. When we change for projections and positions, different projections often require modification of exposure factors, like going from AP to lateral. An increase or decrease in the amount of tissue should determine any change in exposure factors for oblique and lateral projection. So again, think about the 4 centimeter to 5 centimeter rule of thumb that we talked about earlier. So for example, if we're using 80 to 25 on an AP lumbar, then for an RPO or an LPO, we're going to need to increase the mass by about 1.5 to 2 times, because that average thickness, think about the path of the central ray when you're considering that. The lateral, you're going to increase the mass by about 3 to 4 times, because the average thickness increases about 8 centimeters. We're just a lot thicker generally in the lateral than we are the AP. Especially if we're laying down, because what happens when we lay down? Everything sort of spreads out, right? When we're standing up, it sort of just stacks up, right? With your lateral spot, meaning L5, S1, you're going to use the mass for lateral and also increase your KVP by about 10 to compensate for that additional bone thickness in the pelvis. So remember, you have lots of extra bone that you're trying to go through when you're talking about L5, S1, because that sits right in the center of the pelvis. So you're going to increase, you're always going to increase your technique from AP to lateral, and then also generally from not only the lateral, but from the lateral to the lateral spot. If the patient comes and they have a cast or a split, fiberglass generally doesn't require a change in technique. Those are the newer kind, like the colors. How the kids or whoever can pick out the color of it. So those aren't quite as don't really need as much adjustment. Plaster, definitely. I don't even know if they still do the old plaster types of cast, but plaster does require an increase. May use the 4 to 5 centimeter rule to adjust the mass if it's dry, more if it's wet. It always takes more when it's wet. Splints only require adjustment if they're in the path of the central ray. So for example, if I have a splint, everybody knows what a splint is, on my wrist, then when I'm doing my lateral, does the splint affect the central ray or the path of the beam? No. So in the lateral, I probably don't need to make an adjustment except for the fact that I'm going from PA to lateral. But in the PA, then I may need to adjust a bit, because the splint's just going to add to what we have to get through. Contrast media. Now here's where it gets a little tricky. Not really, but so we talked about contrast media last semester, and we said we add contrast media to increase contrast between structures that normally you really wouldn't be able to differentiate between. And so when we talk, and y'all will be getting into this a little bit later in the semester with Yolanda as well, when we get into upper GIs and very minimums. But double contrast upper GI or BE means that we're going to give them not only contrast like barium, but also some form of air. So with upper GIs, we give them crystals that they throw back in their mouth and swallow. and it creates air in their stomach. So it's sort of like pop rocks. Y'all remember that? I think that's what they were called, where they fizz, or like Alka-Seltzer, how it fizzes up. That's what that does. So when you're using double contrast, then you're going to increase your KVP by increments of 10, which is about 15%, until you reach 90 to 100 KVP and adjust the mass accordingly. So notice that about 90 to 100 is the KVP you want to get to for double contrast studies. It's more for single contrast studies. It's 110 to 120 because you don't have that air in there. It's all barium. So it's going to be, you're going to need to have higher KVP because it's all barium. So, and then you're going to just adjust your mass for the change in body position for other projections, again, such as your oblique and lateral. So let's look at an example so you can visualize what I'm talking about. So let's say we're doing a BE with air. And on our scout, we always do a scout to make sure that they're cleaned out. So it's just a regular old abdomen before we get started. And so let's say we used 80 at 25 on that preliminary scout film. Once we put the barium and air in there, then we're going to increase our KVP by increments of 10 or 15% until we get to 90 or 100. So in this case, we only had to do one adjustment. Do y'all see that? We increased from 80 to 90. So what did we do to our mass? Cut it in half. You're still doing the same thing that we learned last semester when we adjusted KVP by 15%. So if we increase KVP 15%, we do what to the mass? Okay. Cut it in half. We're doing the same thing. It's just that we're going to do that till we get to the optimum KVP for patients we're doing double contrast barium studies. If it's a single contrast, remember we need to get to about 110 to 120. Yeah. So from 80 KVP to 25, so 80 to 90, we're going to cut the 25 in half. Now, can we use 10 anymore after 90? No, because now we're out of the 60 to 90 range, right? So we have to actually do 15%. So 15% of 90, you add that, and you cut your mass in half. You do it one more time. That gets us to 119. That's close enough. So we would use 119 at 3 mass if we were doing overheads after we gave barium. Okay, so that's how you have to adjust when you give the patients barium or contrast. Any questions? Okay, now we're going to get to the fun stuff, the pathology. Okay. So pathologic conditions can alter the absorption characteristics of the part being radiographed. You're going to find that they are classified as either additive pathologies or destructive or subtractive. You can use the same terms. So additive or subtractive pathology. Properly reading the X-ray requisition, taking an adequate history, and close observation of the patient are essential responsibilities of the radiographer. That's from the Carlton book. And what that means is that's why we stress so about getting a patient history or looking at do y'all still get paper requisitions? You still have like papers that they give you when there's a patient there, or do you have to just see it on the computer? So it should say what their condition is. Do they have emphysema? Do they have, atelectasis or pneumonia or whatever? Because those pathologies can affect the absorbing characteristics of the part. So additive conditions are abnormal or pathological conditions that require an increase in technical factors. That makes sense. If it's an additive condition, you have to add to the technical factors. Think of it that way. To attain proper exposure to the image receptor. Yes.
What is additive condition?
It means like in addition to, like increasing. So your additive means it's increasing the absorption characteristics of the part. So you have to add to your technique to compensate for that. Does that make sense? Additive means it's increasing. Subtractive means it's decreasing. Or destructive is the other term for that. So additive conditions cause the body tissue possibly to increase in thickness, to increase in effective atomic number, to increase in mass density, meaning how close the atoms are together. Additive conditions mean there's going to be greater attenuation of the beam, so you're going to need more technique to achieve the proper IR exposure. So it all sort of generally makes sense. Additive, it's adding to those things. It's increasing these things. Therefore, you have to increase your technique to compensate for that. All right. Destructive is just the opposite. So those are pathological conditions which require a reduction in technical factors. So if it's a destructive or subtractive condition, you don't need to use as much because the tissue thickness could decrease, effective atomic number decrease in the density, meaning again how tightly the atoms are packed together. So you have less attenuation of the beam, so you need less technique to achieve the proper IR exposure. Does that make sense so far before we move into the specific condition? So if it's an additive condition, you're going to have to increase your technique. If it's a subtractive or destructive, you're going to have to decrease your technique. Now, what to change? It's not always necessary to compensate for all additive and destructive diseases. It depends on the extent of the pathology as to whether or not you need to make a change. Okay, it's going to require clinical judgment and experience. That's going to come with time from you being out there working. Your Faber book says to increase or decrease KVP for either additive or destructive conditions. So books cannot agree. I have 3 different books that say 3 different things. I don't think the registry is going to ask you the question, hey, would you increase KVP or mass for an additive condition? Because the books can't even agree, okay? So your Faber book says you increase or decrease KVP. So in other words, you're changing KVP if it's additive or destructive. You either increase KVP or you decrease it, depending on if it's additive or destructive. The Carlton book, which we used to use, says to increase KVP for additive, decrease mass for destructive. And then Quinn-Carroll's book says increase overall technique by 50% for additive in an advanced stage. So you can either increase the mass or the KVP, or you can decrease it if it's destructive. The bottom line is to know that if it is an additive and it's pretty progressed, then you would increase one or the other. Or if it's destructive or subtractive, you would decrease one or the other. They can't agree, okay? So I'm not going to ask you a question like that because it depends on what book you're reading, right? One very important thing is that AEC generally compensates for most pathology, which is awesome, right? We don't have to really think about it like we would if we were setting a mass value, right? Because the AEC is just going to shut off whenever it reaches that preset charge. So if it's an additive condition that the patient has, is the AEC going to stay on longer or shorter? Longer. If it's destructive, like pneumothorax or emphysema, then it's just going to cut off quicker. So that's the beauty of the AEC. Once that preset charge is met, the timer is just going to terminate the exposure, and it should be properly exposed. So where it becomes an issue is if you are manually setting your mass values like we do in lab, because we don't use the AEC. So we're going to look at some conditions. These are just a few that I find interesting. So acromegaly. These are additive. We're going to do the additives first. So acromegaly is a disorder in which the pituitary gland produces too much growth hormone during adulthood. So anybody remember Andre the Giant, the wrestler? This is what he had, acromegaly, where they're just massively larger than normal. Everything, look at the size of the skulls. I mean, everything is just bigger. Enlarged hands and feet, especially enlarged facial features. Ascites is going to be one, you've probably already seen this in clinic, because several of y'all are shaking your heads, especially if you're in room 3 at Memorial. Patients come in there all the time for abdominal series and they have ascites. So it's accumulation of fluid in the abdominal cavity. It's a ground glass appearance. Fluid distension makes the skin tight and the belly hard to touch. Did you touch them and they felt like a rock? Did anybody, like when you're trying to find like where's the crest and you're like, it's like touching a cinder block. You can't feel. It's so hard. They may require more than a 50% increase in technical factors. It just depends. And that's where your clinical experience is going to come into play and your text that you're working with. So do y'all see how ground glass that looks? It's just so much fluid in there. Everything is just so gray because there's so much fluid. Cirrhosis. You can see the ascites pointed out in this picture here with the cirrhotic liver and the normal liver. Cirrhosis is when normal liver tissue is replaced with scar tissue. So this often comes from people who abuse alcohol for sure. And you'll see that ascites goes along with cirrhosis a lot of times. Pneumonia is going to be one very common for you to see when the air sacs fill with fluid or pus. There's just infection in there. So this is a pretty significant pneumonia here. So do you see how that is additive? Because it is adding to that part. Because normally there's just what in the lung? Air. Here there's now stuff in there. So that's adding to. Again, if the patient has pneumonia and you're using the AEC, you're not really going to have to change anything. It's just going to time out whenever it reaches that exposure. Pulmonary edema is another one. Edema means what? What does the word edema mean? Swelling. Yes. Yes. So fluid accumulates in the air sacs. Most common cause is congestive heart failure. The heart just cannot keep up with the fluid volume. So basically these people feel like they're drowning, right? They can't keep their hearts can't keep up with pumping the fluid like it should. So it just starts to sort of settle in the lungs. So they sort of feel like they're drowning. It's not a fun thing to go through for sure. Osteoblastic metastasis is the spread of bone forming cancer. So we're going to see that there's osteoblastic and osteolytic. And so with osteoblastic, there's just more bone being formed. You see all of those very dense areas throughout this poor patient's pelvis. So that's why it's additive. Paget's disease. Generally, you only see this in the more progressed stages of Paget's disease. Your book actually lists Paget's under both categories. Pretty sure I can't remember the page number, but it's in it should be in somewhere between 217 and 229. There's like a chart that has your additive conditions and your subtractive, and so it puts like progressed Paget's in the additive and early stages of Paget's in the destructive. I'm pretty sure that's what that does. Do you have it there, Noelle? What he did? I was looking. Keep going there. It'll get to pathology. Because the new one, I've been looking at the new edition and it looks different. Yeah, so let's see if Paget's is in, but yes. So they have Paget's listed under both additive. And so Paget's is only additive in the very progressed stages. And you can see this bone is just a lot denser than a typical normal bone. Edema is what we just talked about, swelling from injury or inflammation. You can see right here the extra swelling in this ankle. Sclerosis is abnormal hardening of the body tissue. So quite often when you're at the ortho places and you're doing standing knees, they'll look a lot like this because they're sclerotic, they're bone on bone. And you see how very white those edges of the bone are, that's the hardening, that abnormal hardening that happens in a lot of people as we age. Now, some destructive conditions let's look at. So I know you have probably seen this if you've been in room 3. They do lots of bowel obstruction patients in there. So it's a blockage of the intestines. So there's a lot of what in there? What is that a lot of in there that we can see stacked up?
Air.
Air. Like it looks like if you stuck a pin in them, they would fly around the room, right? All of that is extra air that's not typically in there. So that air is a lot easier to get through than normal tissue, right? Because the atoms are spread apart and the atomic number. Emphysema. Have y'all seen this on patients where it's distension and rupture of the alveoli in the lungs? They're generally very causes a very long looking lung, a very flattened diaphragm. Do y'all see this? You know how most normal lungs, that diaphragm is very curved nicely on both sides, and here it's very blunted. The lungs are blunted and the diaphragm is very flattened. So again, this is destructive because there's so much air. There's distension of the alveoli. So there's a lot more air than they're doing, which sounds like that would be a good thing, but it's not, right? Pneumothorax. Do y'all see this one? Do y'all see the pneumo on there? So which side, I know you can't, of yours, left or right has the pneumo? The left, for sure. You see it, the lung has completely collapsed. This is the lung outline right here. This right here. See how in this area out here, we cannot see lung markings at all. It's because the lung has completely collapsed down. So this would be considered to be a destructive condition. This is the atelectasis. Y'all don't have to know this, but this is considered atelectasis, and it would be actually additive because now it's just all lung tissue on lung tissue with no air in there. So they would have to put a chest tube in to this patient to relieve that, get that air get that lung reinflated. Osteoporosis, you've probably all heard of because you watch television and you see all the commercials telling us ladies as we age that we need to, take our calcium, and it's when the bones become weak and brittle, and you can see how do y'all see how this vertebral body, several of them, this one, all where these arrows are pointing, those vertebral bodies have done what? Collapsed, right? They just collapsed. They've lost their height. And so they can go in and do surgery called kyphoplasty. Have y'all been to surgery yet? You started this semester? So kyphoplasty is where they actually go in there and they try to put cement into the vertebral body to try to keep it with a little height and with some stability. So here's the osteolytic metastasis. This is spread of malignancy throughout the bones that decreases bone composition. So in the osteoblastic, do you remember how we saw like bony tumors throughout? So it increased, it added to the bone. Here, do you see it looks like punch outs? See, it looks like parts of the bone have just been punched out. So that's what all of these tumors are here. All of these. That is not good. And then osteomalacia is softening of the bones. You can see that at the end of the bone there. So, do I expect you to look at an image and diagnose it with having a pneumo, having pneumonia? Is that within our scope of practice? Absolutely not. You're going to learn to do that. You're going to see, and you're going to, this patient has a pneumo. I gotta make sure this gets read immediately. But you're not going to be asked like a test question, diagnose what this patient has. I may say, show you a picture and say, this patient has pneumonia. Is this additive or subtractive condition? And you would say what? Additive. Pneumonia is additive. If I said, this patient has emphysema, what kind of condition is it? Subtractive. Emphysema is subtractive because it has all that extra air. So you do have to understand, you know, if it's additive, and you can look at it most of the time and tell if it's additive or subtractive. And understand how it being additive affects the attenuation of the beam. So let me just, we have a couple of minutes here, so let me just speak on that real quick. Let's go back to I have that. Okay, here, where it says, and so this is where you, it seems a little counterintuitive when we talk about it this way. It's sort of like the unsharpness deal. Like when I go about unsharpness, when it says that additive conditions cause greater attenuation of the beam, what does that mean? What does greater attenuation of the beam mean?
Through to the aisle,
Yes. Because of what?
absorption or scouting.
Yes. So exactly what she said. There is less radiation passing through to the IR because of either scattered, more is being scattered or more is being absorbed. So when we say it has greater attenuation of the beam, that's why we have to increase the mass to compensate for that loss. That's why we call it additive. Exactly right. So subtractive would just be the opposite. It would be less attenuation of the beam, which means when it's a subtractive condition, more of those photons are probably going to make it to the IR. So we don't need as much mass for things like emphysema. It's a big one. Pneumothorax. Obstruction in the abdomen where you have all that extra, you have all that air that's spreading the intestines apart. So the intestines are no longer like collapsed on one another. They're being spread apart. So that's easier. Air's easier to get through, right? Than tissue. All right. Any questions? So if you notice on your outline, instead of RadTech boot camps this week, you have something different. So let me just show you real quick. I'll make sure that it's hopefully it's visible if I oops, let's see. And I do want to look at that for a minute too. Exposure technique chart. Here it says exposure techniques assessment. I don't know why there's a 2 out there. I think I've changed it or something, had to rename it. So you're going to click on that. It looks like you're going into a test. It's not something that you have to use Respondus on. You can use your books, your notes if you want to. Try to answer them, you know, without, but you only get one chance. So if you have to look at your books, that's fine. That way, maybe it's going to reinforce that material for you. But it's just an assessment on what we just went over. How to change mass for differences in part thickness and that kind of stuff. So instead of RadTech boot camps this week, this is what you have due Sunday night.
Is it time?
No, it is not. Let me do something. Let me look at something really quick. questions about? So here's the key that's available. This, for the next 5 minutes, was there anything that you, for talking about beam restrictions, filtration, grids, was there anything that you needed clarified here off of this or just in general before you take the test? This is pretty comprehensive study guide here. So if you can answer these questions and you should be fine for the test. I had tried to skim through them and see if there was anything that maybe typically gives students a trouble, but nothing? Okay. All right. So isn't it today that Lacey's coming in? Was that today?
That's what you said.
That's what I said. Okay. Whew. I forgot. She was gonna try, she's not gonna come till like 8:50. She thought y'all might need like a bathroom break or something. So just make sure you're back in here at, 8:50, 8:49, because she's just gonna give you some options for being full-time in the summer. And getting the opportunity to take a few things that could apply towards CT if you were interested in CT. So just make sure you're back in here for that. Okay.